Dr. Phyllis Cavens, a pediatrician and medical director of the Child and Adolescent Clinic at Longview in Vancouver, Washington. Child and Adolescent Clinic is a physician-owned private clinic with 11 pediatricians and 2 pediatric nurse practitioners and a support staff of 60, serving 17,000 patients. We are an NCQA Tier 3 certified patient-centered medical home. We are committed to providing care to all our patients who seek our services, regardless of insurance type, either commercial or Medicaid. Currently, 75% of our visits are with Medicaid patients. Thus, our patient population is medically and socially complex, with increased risk factors such as parents with high ACEs scores and families impacted by social determinants of health, including food scarcity, house instability, and exposure to violence. Many practices across the state of Washington limit or cap access to Medicaid patients because Medicaid funding does not pay for the cost of care. This creates the challenge: how do we provide well child care and chronic disease care for the Medicaid child with limited number of contracted and dedicated physicians? Thus, inadequately funded care limits capacity to provide care. Inadequate capacity limits access to care. Access barriers drive down well child rates. How to overcome these barriers to well child care and improve rates is the topic of our presentation. Why is well child care important? Why do we care about these well child visit rates? Why don't all children receive well child care? These are the questions we aim to answer today. Well child care is the foundation of pediatric primary care and makes up 25% of our visits during the winter and 50% during the summer when there's less illness and the children are out of school. As trusted pediatricians, we partner with our families to promote and ensure the health and well-being of their child by addressing the physical, dental, nutritional, health, developmental, behavior, social emotional health, plus ensuring environmental safety and age-appropriate educational opportunity. Our chief tool is anticipatory guidance to educate the parents, build their confidence so they may achieve success in addressing illness, injury, behavioral issues that may arise between well child visits. Our mutual goal is that their child will develop healthy bodies, minds, emotions, attitudes, thus growing into a healthy, productive adult. Bright Futures. Bright Futures is a set of principles, strategies, and tools that are theory-based, evidence-driven, and system-oriented that can be used to improve health and well-being of children through culturally appropriate interventions that address their current and emergent health promotional needs at the family, clinical, community, health systems, and policy level. A quote from a 600-page book called Bright Futures. It's a system of preventive pediatric health care that has been developed by the American Academy of Pediatrics and is updated every year. This is the busiest slide you'll ever see. 156 dots, each representing a task to be accomplished at a well child visit. And if over the first 21 years of a child's life, you have provided 30 well child visits, performed all 156 tasks, and have been available 24/7, 365 days per year, you will come very close to achieving Bright Futures Healthy Child goal. Now, to define the titles and the terms, Bright Future is a preventive and health promotion guide for children's health supervision and care. Early and periodic screening, diagnosis, and treatment, known as EPSDT, is a federally funded program matched by the state that contains the CPT codes for each of the dots, and with adequate documentation allows billing for each service. When documented, each dot also represents a process measure that yields a HEDIS score. Bright Futures is value-based well child care. HEDIS rates drive value-based payment. Here's the second busiest slide. Our immunization schedule for children 0 to 21 years of age. This is how many parents initially describe well child care. I'm going in to get my shots. It also illustrates a very complex schedule for 17 vaccines to be given 1 to multiple times on the same periodicity schedule of well child care. 95% of the children in this Washington state have insurance, commercial or Medicaid. Approximately half have Medicaid. This slide shows trend lines for well child visits at child and adolescent clinic since 2009, divided into children aged less than 2 years, preschool years, elementary school years, and teen years, tracked by CPT code for each age group. Of note, the overall rate has risen from 45% in 2009 to 70% in those 7 years. And significantly, teens have the lowest rate, having gone from 25% to nearly 60%. The teen population has been a huge challenge because of the marked increase in behavioral health problems, and without annual well child visits, the opportunity for early intervention is lost. No matter if your clinic has 2 pediatricians or 22 clinicians, they all are physician champions on the care team and have responsibility to understand, develop, and implement these 7 population health data approaches. Another important member of the team is the EMR data manager. This person must be trained in the use of your EMR to collect and stratify your data to produce usable process rates and outcome measures. The end result is that your clinic will improve your system of healthcare, improve your patient's health, plus deliver family, patient, and physician satisfaction with the care. The following 3 speakers will discuss how and the why of these 7 data programs. Listed are empanelment, developmental and behavioral health screening, population health management, cohorts by age, diagnosis, or program, care team member task lists, and care plans. The last item then is our payer partnership and how it drives rates. When you negotiate your MCO, Managed Care Organization contract, you should request monthly Excel reports from that MCO. Those reports should contain current demographic of the assigned patients, of your assigned patients, with monthly adds and terminations. Patients not seen in the last 12 months, patients with no well child visit in the last 12 months, patients with greater than 2 ED visits in the previous 6 months, a daily report of ED utilization in the prior 24 hours, claims-based HEDIS data reported quarterly with the prior year's benchmarks for each PCP and clinic, and the foster care HEDIS data reported separately from the total MCO data. The monthly MCO reports will make your in-house clinical data reports more powerful and accurate as you negotiate value-based payment for your value-based care that has produced outcomes above the MCO benchmarks. Next is an audience quick poll.
All right, so that we can get a good idea of who is on the webinar, go ahead and answer the poll. Are you a primary care provider? Are you part of an MCO? Are you a clinic manager? Are you employee of the Washington State? Or are you somebody else? So go ahead and you should see the poll and answer it. If you can't see the poll for some reason, you can also type in the chat box who is on the poll. We'd like to know. We'll give everyone a couple minutes to just answer those questions. And it looks like getting some things, it looks like we have 60% Washington State employees, we have 20% clinic manager, and 20% primary care provider. Now it's actually changing, so I'm giving everyone a little bit more time. All right, so it looks like we have 17% or 15% primary care provider, 15% clinic manager, and about 60% state employees, and 7% who identify as other. So I'm going to go ahead and close the poll. Thank you very much for voting.
Good morning. This is Julie Nye. I'm an RN at Child and Adolescent Clinic. We are often asked, how do we address empanelment? When new patients register at Child and Adolescent Clinic, they choose a primary care pediatrician. After establishing care, appointments are offered with this pediatrician first, with this emphasis that well child examinations be scheduled with the PCP. Patients can change their PCP at any time according to their preference. Clinicians can suggest a PCP change and message the front desk to update the chart if the patient agrees. To determine panel size, our clinic uses the industry standard for pediatrician PCP panel size, which runs between 1,200 and 1,500 patients per PCP. We first determine visit capacity. This is calculated by first determining the average number of visits per day over the past year, and then multiplying that number by the number of days a clinician is in the office. We then determine our visit demand, finding that our average pediatric patient comes in 3 times a year. So by dividing the number of visits a clinician can actually see by 3, this gives the number of patients that a clinician can reasonably care for. How does panel size affect patient care? It is no surprise that clinicians who have a supersized panel have trouble keeping up with well visits, chronic care visits, and acute visits for their patients. This slide illustrates that. PCP panel information can drive improvement in quality measures. We run outcome reports by PCP and then recall by PCP to improve outcomes. When you have a clinician that excels in a particular measure, ask how are they achieving that success and then copy it to others. We encourage an annual well child visit in the month of the child's birthday with catch-up time in the summer. When clinicians have openings in their schedule, we recall for well child exams that are overdue. Right now we're recalling for children who will be entering kindergarten in the fall and are behind on their well child visit. At the beginning of summer, we began recalling middle school and high school students who may need a sports physical and well child visit. In the fall, recall your patients with asthma to get them set for the school year with an asthma review visit and a flu shot. The empanelment approach to cost quartiles is based on the knowledge of our pediatric care delivery and finance system that reveals 1% of children consume 1/4 of the cost in care. 5% of children consume 1/4 of the cost of care. 14% of children consume 1/4 of the cost in care. And the remaining 80% of children consume 1/4 of the cost in care. The cost quartiles follow the 1, 5, 14, and 80% rule and can be managed in quartile cohorts. Looking at this slide, the top 1% of patients are in poor health and have costly, complex, chronic disease and are managed in health homes. The next 5% of patients are in poor health and have complex, chronic disease and are managed by care coordination system. The next 14% of patients are in poor health and have chronic medical and behavioral health diagnoses and are managed by bi-directional exchange of information and community-based care. The remaining 80% of patients have fair health because of the impact of social determinants of health, such as poverty, and are managed in a whole child, family-centered medical home. Empanelment makes managing your behavioral health patients easier and better. When the family brings a child with a behavioral health problem to the clinic and sees their own PCP every time, the family builds a trusting relationship and will engage in recommended treatment. Identify your patients with a behavioral health diagnosis, form a cohort of patients, and track them in your chronic disease registry. For those that have been referred, it is most important to maintain a bi-directional exchange of information so that follow-up may be initiated if appointments are not made or are missed. Team conferences are valuable to discuss progress, medication management, exchanges in severity, emergency department visits, and hospitalizations. Co-managed, coordinated care plans allow our PCPs to stay involved in their care and decrease costs by reducing the duplication and fragmentation. And next, we will have another audience poll.
All right, so here's our next poll. Does your clinic monitor well child visit rates? Yes or no? Okay, and it looks like we have 19% voted. So far, the 19%, everyone says yes. And we'll give everybody a little bit more time. It looks like we have 25% have voted. All right, so I'm thinking we have about 38% who have currently voted, and I'm thinking that some of those people that are on the call are state employees and we don't do well child checks, although we do believe in them. So I'm going to go ahead and close the poll. Thank you so much. And I am going to turn it over to Searing.
So Melissa, I have control of the screen here?
You sure do.
All right, great. All right, can you all see my screen okay?
I can. It says waiting to view, so we just need you to say that you want to say yes.
Let's see. So it just disconnected me for a second here. I'm going to try reconnecting. Give me 1 second, okay?
Okay.
Alrighty. Melissa, if you could transfer over the screen to me one more time.
Yep. It still says waiting. It says, let me just take it back really quick.
Okay.
And then let me try and give it to you. Here you go. Okay, so it says waiting to view Sarings. There you go. I see it, but I don't have your presentation's not up.
Okay, it'll be up in just a bit. All right, how are we doing now?
Great, I can see that. I think everyone else can see it too.
All right, excellent. Well, thank you, Melissa, and good morning, everyone. This is Sering Leva, so I'm a pediatrician with Child and Adolescent Clinic, and I'm based at our Vancouver location. So far we've shared an overview of well child care visits at our clinics, the numerous services that we provide during these visits, also shared the importance of collaborating as data partners with our MCOs on empanelment and co-managing care with our behavioral health partners. So I'd like to reinforce the importance of these as we move more and more towards value-based care and payments. To that end, I'd like to briefly review HEDIS and share with you some of our clinic's well child care HEDIS measures over the last few years. Then finally, I'd like to highlight some underappreciated services and opportunities that add significant value as part of the well child care visits before passing the baton over to our next presenter, Mary Alice. So as you know, HEDIS is the most used standardized performance measure in managed care, and the NCQA uses these measures for Medicaid, Medicare, and commercial plans. In fact, it's used by more than 90% of America's health plans. So some of the pediatric-specific HEDIS measures include management of ADHD, asthma, immunizations, and well child care, among others. So as you heard, it's worth noting here that the MCOs may have data that look quite different from the clinic's own internal data, and this can be due to empanelment, as you heard, and different inclusion criteria and other issues. So again, it's very important to work closely with our MCOs on more data sharing and having a more accurate patient panel. So now the three well child care specific HEDIS measures. So the first one is looking at children who have completed 6 or more well child care visits on or prior to their 15-month birthday. Secondly, children 3 to 6 years of age who have completed 1 well child care visit during the measurement year. And then finally, adolescents and young adults 12 to 21 years of age who have had 1 well child care visit during the measurement year. So let's look at the trend for 6+ well child care visits by 15 months of age for our clinic. As you can see in the legend below the graph, our averages over the last 3 years have been below the benchmark of 60%, though the last couple of years averages have been looking better than 2015. Now we've recognized that we have some work to do here, and we've looked at how we're doing with 5+ well child care visits by 15 months of age. So here we are. We're not too far away with our averages over the last couple of years being around 57% for 5+ well child care visits, and we see an opportunity here. So one of the strategies we've discussed is that if we identify infants around 6 to 9 months of age who are not up to date with their well child care visits, we may consider catching them up by having them come in every 2 months for well child care visits rather than every 3 months until their 15-month well child care visits. Next is our trend for the 3 to 6 years of age with 1 well child care visit during the measurement year. Now these numbers look better, and we've improved our averages over the last 3 years, as you can see, with our 2017 year-to-date average being over 78%. So similarly, with our adolescent well child care visits, We've shown improvement over the last 3 years, and our 2017 year-to-date average is over 58% and above the benchmark as well. So now I'd like to take us back to the barriers as shared by Dr. Cavens and talk a little bit more about our patient population, having limited number of dedicated providers and the growing number of state and Medicaid insured patients who have limited options and have been waiting a long time to see us for their well child care visits. So we appreciate having the opportunity and responsibility to optimize the value of these visits for our children and our families when they are in our clinic. So along with discussing nutrition, growth, giving immunizations, I'd like to highlight some of the underappreciated services that we provide during our well child care visits that provide high value, especially in our population. So these include early detection of developmental problems. Nationally, 1 in 4 children less than 5 years of age are at moderate to high risk for delays. Unfortunately, less than 50% of children with developmental delays are detected prior to school entrance. So during well child care visits, we can detect and refer them for early intervention, which can improve their skills and abilities, future school performance, and success in life. Prevention and mitigation of illnesses. Along with providing education and advice on preventing illnesses, one strategy we've implemented includes sharing what we call a cold pack prescription with families who have difficulty affording over-the-counter medicines like Tylenol, ibuprofen, Pedialyte. So if they have access to these when their child is sick with a viral upper respiratory or a gastrointestinal infection or a minor ear infection, it can help them from getting more sick and reduce unnecessary clinic and ED visits. We also provide oral health education, apply fluoride varnish, and refer our children to dentists during their well child care visits. We also see our well child care visits as an opportunity to provide guidance about calling our advice phone lines, which are available 24/7, better inform families about our evening and weekend urgent care hours to prevent unnecessary emergency department use. And finally, it's during the well child care visits that we can discuss and address some of the major drivers of health. Now, if we're truly serious about improving the overall health and well-being of our children, then we must think more broadly and we must look more closely at some of the underlying determinants of health. As you can see, along with traditional health services playing a smaller role, there are other determinants that include social circumstances, environmental exposures, as well as genetics, and I would add epigenetics here, plus behavioral patterns that can be strongly influenced by adverse childhood experiences. Excuse me. So most of you have probably heard of adverse childhood experiences, or ACEs. They include multiple forms of childhood adversity, including household dysfunction, neglect, and abuse. Now, ACEs can be considered the most powerful determinant of public health with population attributable risk. That's the portion of each condition attributable to ACEs, ranging from 22% for asthma, as you can see in the image below, to 67% for suicide. So we have the opportunity to screen for ACEs during our well child care visits and impact positive change by raising awareness and offering support. Now, recognizing the importance of these social and other determinants of health, we found it helpful to screen for them using validated tools. With every visit, we ask our families regarding food and housing insecurity. This was driven by one of our pediatricians, Dr. Abel. And so when families answer yes to these questions, we can provide them, offer support, and provide them with a list of community resources. I've championed screening for maternal postpartum depression at our clinic. We've been doing so over the last year. We screen parents at 2 weeks, 2 months, 4 months, and 6 months well child care visits. And if they screen mildly positive, we provide them a list of community peer support and other resources. And then for those more concerning, we can make sure to connect them with their OB, their PCP, or other mental health provider to not only improve the health and well-being of the parent, but of the child and the family as well. We screen for our children 9 years of age and older with the RAP survey to identify and discuss risky behaviors impacting health, well-being, and academic success of our adolescents. And we're constantly looking for ways to screen for ACEs and look at other helpful socio-emotional screening tools as well. Now, all of this requires time and resources, and with our providers and staff already being stretched thin, so in order for us to continue offering these high-value services in a sustainable fashion, we need partners within MCOs and other state agencies who will help us advocate for children and help us secure payment for these high-value services. Now, our patients and families have also benefited significantly from care coordination. Families of children with complex chronic conditions may be overwhelmed by all the appointments, specialists, DME, travel, translators, hospital follow-up, and community support that they need. So it's during these well child care visits, PCPs can connect these families with care coordinators, and they can help families navigate the health system and get the care that they need, leading to better outcome for our patients and families. The Healthcare Authority assigns costly, complex patients with chronic disease according to a PRISM score and provides funding for care coordination via health homes. Our clinic staff also helps children with high social complexity, even though they may not be high enough, they may not have a high enough PRISM score to meet criteria for health homes funding. So we would again appreciate support in funding in other ways for such high value services that are currently being provided at our own clinic's expense. And in order for these to be sustainable, having support and partnership with other groups would be much appreciated. So I'm glad that we have a team culture at our clinic in which we constantly look for ways to improve care for our patients. Having regular communication is key, and having weekly QA meetings makes it possible. They're attended by all of our pediatricians, our nurse practitioners, the lead CMA, the EMR coordinator, clinical administrator, and program manager. The agenda is built around topics requested by the team, and we're looking at ways to improve our clinical approaches. We also review our HEDIS and other data during these QA meetings. In addition to working in the team, we also are working on having better communication with other community child advocates. We've invited and had co-management meetings at our clinic with folks from Head Start, mental health agencies, and schools. And as part of the pediatric TCPI, we get to partner with and learn from other pediatric clinics around the state. As part of the AAP Project iScreen, which we recently joined, we're one of 20 pediatric clinics across the nation, learning together and from each other in applying quality improvement methodology to improve screening, referral, and follow-up for development, maternal depression, and social determinants of health. We also enjoy meeting with the Department of Health and various MCOs to provide input on well child care performance improvement project in our state as well. I'll pass it on to the next audience poll.
Great. So I'm going to just pull up this next poll here. And there we go. Okay. Does your clinic monitor HEDIS rates? Yes or no? I'll give you guys some time so far. We only have 17% who have voted. But the good news is, oh yeah, great. It looks like more people are voting, and it looks like most of you do. That's fantastic.
And then there was another one. Does your clinic submit claims for development and behavioral claims?
And we'll just give everybody a few more seconds to finish answering the poll. And that's great. All right, it looks like 86% of you said yes, your clinic does monitor HEDIS rates, and there's 14% who do not. If you have questions too about your HEDIS rates, you can always check in with your practice facilitator who can either help you understand it better and can also set up appointments with your Molina representatives that can go through it with you. All right. Okay, I'm giving it back over to Phyllis.
Great. This is Mary Alice McCubbins. I'm one of the nurse practitioners here at the Child and Adolescent Clinic. And I'm going to kind of talk a little bit in repetition to what has been mentioned earlier, but our goal is to give you a few helpful hints that you could apply to the clinic setting that you're working in to actually implement these great ideas that have previously been identified. I think what's really important is we listen to what Julie talked about with empanelment and how calculating and getting your slide ruler out and find out what you actually can do is really, really key to where we start. However, your EMR holds the key to much of your work that you can do, and it's really important that you get to know your EMR. What we ask our EMR to do is to give us our top 20 diagnoses and then create population-based registry that is unique to our clinic, and that can be very helpful depending on the demographic that you care for. Once you establish your cohorts, you can then work on developing a review of the data, as well as getting a recall and report system established. Again, data driving the importance and allowing you to evaluate and report out, whether that's weekly, quarterly, or annually, on the success and the changes of your empanelment and care plans. Our data looks specifically at, obviously, the well-child visits that we're working on today, but then grabbing those chronic illness that are so important to the pediatric population. Asthma was mentioned earlier by Julie. Obviously, ADHD, some of the behavioral concerns like autism and developmental delay, as well as our chronic illnesses of diabetes, Down syndrome, hepatitis, and hypothyroidism. Obesity, I think, is a lecture in and of itself, and we can talk a lot about establishing care plans with that. I think that that is outside of the auspices of this particular visit, but it is a huge issue for the pediatric population. We go from food insecurity to obesity. Good luck on tackling that. Let us know in the next webinar what you're going to do to help that one all the way around. And I think what's really important is reminding the patients that these well-child visits that we're harping on so much are not just a visit for shots, but a visit to evaluate the patient entirely, bringing about their well-child care, anticipatory guidance, and, oh yes, the preventative services that we achieve with immunization. We established a care plan recall program within our EMR, which we use OP, Office Practicum, and it allows us to actually look at the care plan, identify the visit required, and then send a message, whether that's through email or whether we choose to call. We also have administrative staff that then would send messages into the providers so they get an idea of, gosh, your empanelment patient X has not been seen for their chronic care or chronic illness care evaluation. You might want to set that up. When's a good time for you to do that? So again, the important thing is that data drives the care, and we establish that in a system or a series of programmed plans. So much has been discussed by Sering when we talk about what we do at our well-child visits. Again, food insecurity, homelessness, and harm create a huge situational environment for our patients that certainly increase the morbidity of care and provides an opportunity for us to really visit with the family and see what where their strengths are, where their needs are, and establish whether or not behavioral health is something that needs to be intervened straight away. So our screening for behavioral health and anticipatory guidance really drives the future of this patient. And then again, we're looking at evidence-based medicine instead of just this gestalt of, gosh, that family looked like they weren't doing very well. We need to make sure that we give instructions to our patients. We empower them to be able to take care of those mild illnesses that come about in the winter time, such as viral illness, as Sering alluded to earlier. By providing them this cold pack at our well visits, we also get the opportunity to talk about how is medication administered in your home. What is the appropriate dose for your child at this visit? And our cold packs actually go on a range, so it may be 24 to 35 pounds, and we can say, for today, this is the weight. We can give this dose of medicine up until the age of 30, or the pounds of 35, for instance. And we can then talk about, gosh, you know, what other medicines do you use at home when your child is sick? Do you have a prescription? Gee, what you've stated seems a little bit different than what I would like you to do. Here is what I would like. So it gives you an open opportunity to talk about that, empowering the patient to take care of the children during the illness visit, during the illness season, excuse me, but we're being able to do that as an anticipatory setting. We also make sure that the patient knows that we're available to them and that we want to help them, that we have triage lines 24/7, 365, and can help them walk through this challenge of child rearing and health care. The other thing that becomes very important, whether you're looking at access to care or just the complexity of your patient in general, that we can combine those chronic care illness visits with our well child exam. For instance, ADHD, asthma, and other chronic conditions. Our EMR allows us to open a separate encounter, which I think we spoke to a little bit in our part 1 of the well child care webinar a couple of weeks ago, where you can use a 25 modifier to your E&M to provide both the encounter and well child visit at the same date. We do make sure that we do annual to semi-annual asthma action plan evaluations so that we can have action plans in the school setting, appropriate medications in the home, and then as well as the ADHD medication checks, we can touch base with them from an anticipatory level on how are the kids succeeding generally in their social and academic environment. We do establish care plans that help to key us to chronic conditions and the necessity for additional laboratory sampling or other imaging or interventions that may have been missed by their specialty care manager, and we can pick up as the primary care manager. We want to make sure that the patients and families are aware of the necessity for well child exams and when we have kind of a bulk of appointments available. So we advertise, we use social media, we use the schools and the newspapers to provide information to our community to encourage them to come in. We make sure, like Sering talked about in our QA meetings, that each of our clinicians are aware of what their well child rates are. The empanelment fluctuation becomes a challenge for us, and I think what Phyllis talked about, using the MCO to provide that data for you so that you know those fluctuations in those key 7 points is important. So if you know what your rates are, you can certainly reach out to those problematic patients and say, hey, I noticed that you haven't come in. Why don't you come in today? I have a hole in my schedule. And then really, again, working with the templates to assure accurate billing and coding, because if we're not billing and representing our data appropriately, the HEDIS and well child visits that we get back are not going to be accurate. So having a superb administrative and coding staff really helps to assure that your HEDIS and well child rates are actually accurate. And then, like Sering said, our weekly QA meetings really help us to drive our care. In this population setting in the lower Southwest Washington region, we may have a predominance of one type of care over someone who may live in a different area. So by looking at our specific HEDIS measures and then driving that home in our quality assurance meetings to assure that every one of the providers and the clinic staff has a united front to challenge that topic becomes really important, and you feel like you have such a great team around you. You're not out there alone just fighting the HEDIS goddess, but you're actually providing good care to our patients based on the needs of your demographic. It is imperative that you use your EMR, that you get to know your EMR, that you play with and experiment with your EMR, because, gosh, I'm old, and I remember the paper record and how hard it was to read my own writing, let alone that of the physician that came before me, sorry to say. So it is important that you use the EMR to be your friend, to help you calculate your needs, and then use the recall method to really round up and keep your records or your patient population going. Your immunization schedule is a great way to drive your HEDIS recalls. Looking at, like we said, recalling the school children like Julie talked about today in the spring, and targeting that to whether it's the middle school and sports minded children, or whether it's the chronically ill in the fall who need a new asthma action plan, a flu shot, and a follow-up or refill of their prescriptions. We want to make sure that those kids with chronic care, healthcare needs are being called on a yearly basis. We want to make sure that their referrals are being followed, that the recommendations for the follow-through that you've gotten from the subspecialist is being implemented. And so recalling your chronic kids yearly is important, and then really optimizing the time when the kids are out of school, using the summer to pile in your well child visits when your acute care needs are reduced. We have found in our population that texting really works well. And so, you know, these families have their phones with them. They may not have a computer. They may not even have a home where they have a telephone that they can use on a regular basis. So we text them about 72 hours prior to their appointment, and then give them another reminder call at 24 hours. If we have utilized our well child visits appropriately, we've actually asked them to make their follow-up next well child visit at the time they complete their current visit. And then we tell them, gosh, if your schedule changes, you certainly can call us at a different time and reschedule them. We want to know why our patients are not showing up. We need to poll them, find out what their reason is, and then work from that. We need to educate them on the impact of those missed appointments, how that affects our access to care and their health in general, and where the benefit to the clinic, the patients, the providers, and the child comes in play, and helping them to identify when they don't come in, what impact that's going to be to their overall care. We want, again, like I said, schedule early. Ask them at their sick visits, when was the last time you had your well? Look at your EMR. Look back at the record. Have them go to the front and schedule that well visit right then, making sure that other people on the staff, as well as the front desk and the MA staff, are a part of that. We also want to personally invite them, remind them that we really enjoy seeing them, helping them take care of their children, being a part of their family and their child's wellness, and that we really would love to see them. We give them incentives like stickers and toothbrushes as we apply their varnish, and we demonstrate the appropriate method for brushing their teeth. And then as a part of the Reach Out and Read program, we are providing them a book for their child from the age of 6 months to 6 years. We show them how to utilize the book to explore the developmental stage of the child, and to provide something of fun to the child that they can anticipate and look forward to when they come for their next visit. It's imperative, again, that we utilize the staff. No one person can do anything on their own. So the front desk staff at our clinic looks at the visit each time they check in to determine when was their last well child exam. Can we get that scheduled for them before they set into their next appointment, or perhaps before leaving the clinic? We have the MA staff look again and remind them when their next immunization may be due, when their next well exam or chronic care visit may be due, and that MA staff then notifies the clinicians so that they're clearly aware to reinforce that during the visit. And whether it's the pediatrician, the PA, or the nurse practitioner, we as clinicians really do carry the most weight. So the more we can reinforce what our administrative staff is trying so hard to help us with, the better the patients are going to accept that information. So I really do appreciate you and all that you do in the care of our children. We're going to do a couple more question pools and then open it up to question and answer.
All right, so this next poll is, does your clinic screen for the social determinants of health? Yes or no? Okay, and so we'll give you a little bit longer. We're at 32% and we're about 50-50 of yes, 50% say yes you do and 50% saying you do not. All right, I'm going to go ahead and close the poll. Oh, and then there's another one. Does your clinic screen for maternal depression? Yes or no? And it looks like a lot of you do. That's great. So I'll give you a few more minutes. There's about 32% of you that have voted so far. I'll give you a couple more seconds. And I'm going to go ahead and close the poll. Thank you very much for those of you that voted. All right. Okay, who's next? Okay, great. So it looks, so thank you very, very much. We can take a few questions. We have about 7 minutes left on the webinar. So is there any questions that people have? Okay. And I don't see any questions so far. Like I said before as well, your practice facilitators are here to help you with a lot of these process. So if you have questions, reach out to them. You can email them. The other people that are really great that know a ton about this is the Child and Adolescent Clinic. So go ahead and take a couple seconds, jot down their emails. They're always happy to answer any of your questions that you have or that may come up at a later date.
Hello, Melissa.
Yeah.
I wonder if we take an audience quick poll regarding, does your clinic submit a claim for developmental and behavioral health screening?
Sure, let's see real quick. Okay, let's see what people have to say. Does your clinic submit claims for developmental and behavioral health screenings? And so far, everyone says no. I guess I would like to take that question a step further and say, do you not submit claims because you don't, or do you know that you could submit claims? Okay. So that's something also to talk with your practice facilitator about, or you can also email the Child and Adolescent Clinic. because you can definitely be submitting claims for doing developmental and behavioral health screenings. I'll give you guys a few more seconds.
So Melissa, just to the developmental and behavioral health screens, there are a number of CPT codes, AAP, and if you email me, I can email back with the appropriate codes for the appropriate screens. But
Great.
it sounds like a lot of people are doing screens for social determinants of health and maternal depression, but you should be coding and billing for those to get the reimbursement to support that practice.
Absolutely. I agree. So Kimberly, are you a great person to email for that information?
That would be great, Melissa. And the other thing I can do is put together just a one sheet on a one sheet flyer on which codes to use for which screens, and send that. And then you can disperse that out to all the participants.
Wonderful. Wonderful. So I will do that. So those of you on the call, Kimberly Robbins is going to put together a one-page sheet of what codes to use in order to get reimbursement for doing developmental and behavioral health screenings. And I'm going to go ahead and email that to the participants. So that would be extremely helpful. All right, so thank you everybody who participated. This has been a joint webinar from the Pediatric Transforming Clinical Practice Initiative and the Child and Adolescent Clinic. Remember, if you have questions, to reach out to your practice facilitator or reach out to any of our presenters that were here today, and their emails are up on the screen. All right, thank you. Do we have any comments from our presenters? All right, thank you everyone. Have a fantastic day.